So what I'd like to do today is to go through really a framework. And most of the time is going to be spent going over the approach to your pre-travel assessment. So someone's coming to you and they're interested in going somewhere. So we're going to really look at organization and resources. So the big items are going to be vaccines before travel, traveler's diarrhea, and malaria prevention. Then at the end, there's a couple of cases about some contemporary issues in travel medicine that I want to share with you. So here's a case. I don't have this rigged to the cell phone, so we'll just do it the good old-fashioned way. You're here, and your partner is auditioning for The Bachelor and is leaving for taping in Madagascar in 2 weeks while you're here at this conference. And he asked you for travel advice when you come back. So for hepatitis A prevention, what would you recommend? Would you recommend immune globulin? Would you recommend immune globulin plus the vaccine alone, or whatever has the biggest needle on it, because now you're going to be on call an awful lot? What do you think? How about A? B? Got some Bs? Always do what the hepatologist says too, and I kept an eye on his. How about C? All right, so how about D? You people are too nice. I usually get a few Ds. So Hep A is the forgotten hepatidity, right? I mean, Hep C gets all the press, rightly so. Hep B, wonderful evolutions in therapeutics and what we think of it. Hep A is sort of the forgotten viral hepatitis, because it really doesn't kill anybody or go into chronic phase and all that stuff. Well, it depends on who gets it. If any of us got it, boy, we'd be out of work a long time, wouldn't we, Dr. Sanjal, I think. And mortality, especially if you have underlying liver disease or you're getting up in age. So it's an incredibly important disease in travelers to prevent. And shame on us. This study was done looking at travelers at the departure gates of US airports going to high-risk areas around the world for hepatitis A. And 80% were not immunized. So that's a bad situation. And you might say, well, it's kind of an older study. Hot off the press, presented in October at our international ID meetings, was this outbreak of 29 cases in young adults primarily. And you can see that none of them had received a Hep A vaccine before they traveled. So we have some work to do on hepatitis A. Well, where do you need to go to get hepatitis A? Well, pretty much go anywhere and you're at risk for hepatitis A. You can sort of grade the world in terms of red being higher risk or blue medium risk. But as you know, there's outbreaks even in the green parts of the world as well. So Hep A is everywhere. I want to make 3 points about the vaccines. The Hep A vaccines are just absolutely outstanding. These are some of our most well-tolerated and efficacious vaccines. We have 2 of them, as you know, that are Hep A alone, Havrix and Vacta. The first dose, what I want to point out, gets you very rapid, very high levels of seroconversion. So you give this vaccine, and within a couple of weeks, you're looking at 90%, within 4 weeks, upwards of high 90s protection, which is terrific. That second dose, the booster, which sometimes is 6 to 12 months turns into a year and a half, whenever they come back, it's really designed to get you durability. So it's more getting you the extension of that protection for many, many years. And the modeling of these vaccines goes out a long, long time with that booster dose. So we're not going to be too concerned about the booster dose in our travelers, but that first dose is very important. The other point I want to make is the combined vaccine for Hep A, Hep B, the Twinrix that you're familiar with. There's an FDA-approved accelerated vaccine schedule. So the usual 0, 1, and 6 months, just like the standard Hep B, is fine, but there's an accelerated schedule that can be very, very helpful when your traveler comes to you and says, hey, I'm here, and you say, oh, it sounds like a great trip. When are you leaving? Oh, I'll leave it in a few weeks, leaving in a month. They don't give you a lot of lead time to make some of these vaccine decisions. So the accelerated schedule is baseline, 1 week, 3 weeks, and then 12 months. So if you have a traveler who's hitting the road going to high-risk regions, not just for Hep A, but also Hep B, I really encourage you to consider this accelerated schedule. And what it does, if you can get those first 3 doses in, which takes you 3 weeks basically, then you're protecting them against Hep A, and you're really giving them the first couple doses of a Hep B vaccine. So you're taking someone who's seronegative, and you're probably getting them in the 60, mid-60 or higher protection range against hepatitis B. So it's a good trick to think about. in your travelers. So the bottom line for Hep A, pretty much if you're going anywhere, I would consider going any kind of travel to give the Hep A vaccine. Now, what to do? Well, this is a situation pretty common in travel medicine. You tailor it to your traveler. And so what the CDC says is they would recommend immune globulin, and the advantage there is very rapid protection compared to that antibody response for some groups. What are those some groups? Maybe older adults or immune compromised or chronic liver disease or some other conditions. And so you provide that rapid protection in addition to the vaccine if they're leaving less than 2 weeks. Now, with the seroconversion rates being very high, even at 2 weeks, 3 weeks, 4 weeks, you can see where that tailored approach comes in. So a lot of folks would be very comfortable in this case, in your partner giving just the vaccine alone, as long as you explain, well, it's a couple of weeks, you're going to probably be around 90% protection, have this other option. Sometimes, as you know, it can be challenging getting immune globulin preparations, or people don't want it. So that's something to consider. The World Health Organization took out immune globulin and just says give a vaccines. But whatever you do, if they're on their way to the airport and you have one shot to give, make it a hepatitis A vaccine. So the 3 R's for travel medicine, there's a lot of vaccines. How do we organize them? This is how I think through them. Routine, required, and recommended. So you have them there and they're traveling. The routine, take advantage of it. Just use that opportunity to update them in all the regular vaccines you'd be thinking of anyway. So some of the things we talked about yesterday, is everything up to date? What about a TD or a Tdap or the pneumococcal, et cetera? There are some required vaccines, and really what we talk about here is yellow fever. You don't want someone traveling and they get to their destination and they can't get in because they've either entered a region where they have to be vaccinated, or their itinerary has taken them through even airports along the way that now their final destination says, whoa, wait a minute, you flew through somewhere and we require you to have evidence of a yellow fever vaccine for entry. And then recommended vaccine really has to do with specific risks, unusual risks for your traveler. So the pre-travel vaccines, the routine, the one I want to highlight is the MMR. And so this comes up, and I think it's easy to forget about the MMR in adults in general and travelers specifically. So watch the MMR. The ACIP actually recommends 2 doses of MMR given at least 4 weeks apart for any adult who doesn't have evidence of measles immunity who plans to travel internationally. Now, just to recall, what's that list of items that gives us evidence of measles immunity? At least one of these: written documentation, they've gotten the vaccine, lab evidence, lab confirmation that they had it, or they're born before 1957. So as you're going through, and maybe your EMR helps you with this, mine certainly doesn't, then keep that in mind as one of the forgotten routine vaccines. Yellow fever is an issue for traveling to Africa and South America. And remember, your partner is going to Madagascar. So let's just take a look to see what the CDC says about Madagascar. For yellow fever requirements, the country itself doesn't require you to have it before coming to Madagascar. But if you travel somewhere required of traveling from a country with a risk of yellow fever transmission, they're over 9 months of age, including transit greater than 12 hours in an airport located in a country with a risk of yellow fever transmission. Yikes. Well, we don't remember all that stuff, but we want to know where to go for that information, and we'll certainly touch on that. So that's important, and you wouldn't want to send someone on their way without the proper vaccination, but also the proper documentation they've received the yellow fever vaccine. Now, remember yesterday I showed that long list. The ACIP was very busy between February of 2015 and now. And one of the updates they provided us was a yellow fever booster update. And it really isn't a big deal, but it is kind of a big deal for travelers who frequent these areas. And basically, what they did for most travelers is they concluded that a single dose is lifelong protection and a booster is not needed. Now, there are some caveats and carve-outs here, but what we expect to happen by sometime next year is that these international health regulations will change, and a booster recommendation for most travelers will be taken out of the equation. So that's the update that was put out of the MMWR this year regarding yellow fever vaccination. What I do in these circumstances, we rely on our our VISs, the vaccine information statements, our nursing staff, et cetera, I actually sit down and go through in large detail the yellow fever vaccine with folks who might need it, because what you'll find is you'll encounter a lot of people that have a higher risk of adverse effects. So elderly, immune compromised, et cetera. There's some people that flat out shouldn't get the yellow fever vaccine, or their risk of an adverse effect might be higher than the vaccines we typically deal with. So I sit down and go through it in good detail with them. Now, what about the recommended vaccines? These are really traveler-specific indications. And a lot of these we really don't broach very much unless there's something to highlight. The one I want to focus on today is typhoid. And it's tempting to think of typhoid fever is one of those conditions that, well, you got to be there a while to get it. It's maybe not as relevant for a short-term traveler. But actually, the studies have shown that short-term travel has its risks. And you can see here that in a particular study, about a third of cases occurred in travelers who were only at their destinations less than a month. 6 countries account for about 3/4 of the cases in terms of the destination risks you see here. And in one study, only 4% of travelers had received a typhoid vaccine in the preceding 5 years, despite going to high-risk areas for typhoid acquisition. So again, it's an easy vaccine to forget, but a very, very important vaccine to consider. You don't want to mess around with typhoid fever. Once again, the ACIP was busy, so we had a typhoid fever update in 2015. The good news is it really wasn't an update. There wasn't anything new. It was just a reaffirmation of what we've always been doing. There really weren't any substantive changes. There's 2 vaccines. There's the intramuscular one and the oral live attenuated. And the thing I want to highlight is the booster interval. So this only lasts for 2 years, so you want to boost it every couple years. So in your frequent travelers, they're going to need some frequent boosting. The oral live attenuated every 5 years, and remember, that's the one that you can't co-administer with certain other items, especially antibiotics and so forth, because you'll kill the vaccine strain. Most travel-associated typhoid fever cases that occur when they return to the US actually occur in folks who are visiting friends or relatives. And these are the folks who may not seek pre-travel care because they don't perceive themselves to be at risk of acquiring anything when they go back home. But that's indeed what we tend to see. In fact, VFR, not visual flight rules for pilots out there, but visiting friends and relatives is a common phrase in travel medicine. So be careful when you encounter folks who are going back home, whether it's malaria risk or typhoid fever or anything else. The risk is very real for a lot of potentially very serious infections. And this is a prime source of travelers returning with a variety of conditions. Use the accelerated vaccine schedules. Not only does Twinrix have one, but the standard Hep B monovalent vaccine has one as well. And these are very handy for travel medicine. One of the other things about vaccines, and I alluded to it with the Hep A, but it applies to Hep B, is pick up where you left off. So if someone gets the initial dose and come back for their second dose, but well, magically now years have gone by, you can pretty much just pick up where you left off. You don't have to start over for those particular vaccines, okay? So the CDC website, Travelers Health, is very, very good. It's excellent. I don't work in a travel clinic, but in one of the clinics I work in, I get folks, we have a travel clinic at our university hospital. At the VA, where I staff some clinics, I have the travel medicine cases come through so our residents and fellows can get some experience in this. And so I focus on the ID issues, not the other issues that are very important, like motor vehicle accidents and injuries and other things that are arguably higher risk than their ID issues. But I bring up the Travel Health website not only for us, for clinicians, but also it's an outstanding patient education tool. So I request that individuals spend some time looking at this, and I point out some particular items that might be of interest. They're traveling with children. They're going to stay for unusually long periods of time. Maybe it's a cruise ship. Maybe they're visiting friends and family and so forth. So there's a lot of nice subgroup information here. But we're in clinic giving advice to your partner, and let's go to Madagascar. So we bring up Madagascar, and quite frankly, I just picked Madagascar out of the thin air. I didn't realize what I'd run into when I picked it, but look at all the list of things we got to do. And this is nice. So this Madagascar, any country, the CDC's website will give you a list of the vaccines that you need to consider, from Hep A, Hep B, talks about malaria, polio, rabies, typhoid, yellow fever, etc. And not all of these are mandatory. For example, the rabies would have a lot of considerations. Most travelers don't need it, but some do. The resources for this, that's the travel health site on the CDC. It's good, I think. It's general, and it can't be necessarily as timely as what's going on right now in a particular area, but they do a nice job at keeping it current. The Yellow Book is sort of the classic, and there's many links to the Yellow Book from this website. And then that website I mentioned yesterday, the Immunization Action Coalition, immunize.org, has some nice resources on specific vaccines that are relevant for travelers. Oh man, look at that water in those boats. Woo. Remember, when I get back to Wisconsin sometime after the first of the year, that's just going to be where I want to be. Oh, here's the next case for you. So here's a 33-year-old, and she's going to the Dominican Republic, and she's going to stay a couple of weeks. But on prior trips, she's had traveler's diarrhea. So what would you recommend for helping her manage diarrhea on this trip? Would you say pay closer attention to food and water? Okay, got some hands. Bismuth subsalicylate prophylaxis plus pay attention. All right, got a few there. How about antibiotic prophylaxis, meaning a daily antibiotic plus pay close attention? Nope, no, not many takers there. How about self-directed therapy using ciprofloxacin plus pay closer attention? It's probably the most so far. And don't worry about it, just be happy, enjoy your trip. So let's take a look. I mean, look at that water. Look at that water in the background. It's, it's Wisconsin, it's January, it's February. It's like, get me out of here. Oh my God, look at that palm tree. You can see the fronds here. And above all, look at that smile. I mean, she's saved up. It's a vacation. We get the week off. One bite of that salad and it's all over, right? Traveler's diarrhea is not going to kill anyone, but look at what it can do. 30% get confined to bed for part of that precious week, right? 40% have to change their itinerary because they get interrupted. And I bet a few of you have had to change your itinerary when you've gone somewhere and encountered traveler's diarrhea. 10% develop a persistent diarrhea, which can be problematic. And I think probably one of the most problematic areas and poorly understood is a risk of a post-infectious irritable bowel syndrome after coming back and the organism's gone as far as we know and so forth. But people can have persistent symptoms long after return from travel. So it can be morbidity clearly. The etiology, we tend to think, and I think most people tend to have in their mind, it's an E. coli driven disease, travel diarrhea. And that's true depending on where you go. But I just want to use this slide to highlight the list is actually pretty lengthy in terms of bacterial pathogens, and it varies depending on the part of the world where one acquires their traveler's diarrhea. There can be viral causes, of course. All you need to do is get on the wrong cruise ship, and we all know that, and parasitic causes as well, and of course, a category of unknown. Let's drill down a little bit more over here on the bacterial side, which is the most common. In general, I'm being very general here, destinations in Latin America tend to be the enterotoxigenic E. coli, enteroaggregative. Remember, there's some subgroups of E. coli out there. And these tend to be the ones that are problematic but don't have a lot of antibiotic resistance. On the other hand, if we go to Asia, Southeast Asia, we learned this from our military stationed in Thailand, the rates of Campylobacter resistance to fluoroquinolones are extremely high. And so we start getting into more invasive pathogens, like you see here, with a different slant on antibiotic resistance. So the quinolones, kind of our workhorse for self-directed therapy, may not be adequate for those destinations. Now here's another happy guy, right? He's at one of the most famous bars in the Caribbean. You can see he's got something planned later. I don't know what that is. And he's got his Carib beer here. Now, what's the advice that we all were given at one point in time and that we've probably given to others? If you had one bit of advice to give to this guy, he's on this island, it's don't what? Don't drink the water, right? Don't drink the water. So when it comes to travel diarrhea, if we only had one bit of advice to give, is the best advice don't drink the water, or is it don't eat the food? Make sure the food's hot, okay? So it depends what you eat. And if you look in terms of the risk to travelers, in terms of how they acquire these pathogens, actually it's the food that is more relevant, more important than the water. Now, please don't misunderstand. The water's at risk, the ice is at risk, all that stuff that we think about. But the food overshadows those risks. I used to go to Zihuatanejo a lot several decades ago. You know, when you walk in a nice hotel, that big thing in a tropical destination or anywhere, that big jug of water, you walk in and those little Dixie cups and oh, it looks so good, it's hot out, I've been walking around. There's a constant flow of buses and taxis, Zihuatanejo, which is a wonderful old fishing village, and Ixtapa, this modern, you know, tourist destination, are pretty close, and trucks are going back and forth. So one day walking around Zihuatanejo, I just got lost and was in an alley, and I saw one of these trucks loaded with those water bottles, those big things, in an alley with a garden hose getting, and I didn't know where those were destined to go, but I also hear too, well, Dr. Urban, you know, I'm just gonna go there and drink margaritas. Won't that kill the bugs? Won't that kill the germs? Anybody ever heard that from their travelers? Or anybody ever used that as a rationale? You don't have to raise your hand for that. And the truth of it is, the typical alcohol used to make margaritas and our mixed drinks and so forth will kill a lot of microorganisms, but they won't kill them fast enough at the proofs we tend to use. But if you jack up the proof high enough, you will kill the organism before you consume it. I don't advocate them mixing their margaritas with Everclear and so forth, but that's what it would take. Red wine is more potent than white wine in terms of its microbial side effects, and I'm very jealous of a study done at UT Galveston many years ago showing that Tabasco sauce has very potent activity against Vibrio in terms of killing them, and you probably know that trick already where many of you live. So if you had to give one piece of advice, it'd be the food, but obviously we're going to give more than that. The alternative here is leave this guy alone because he's your father-in-law and he's not interested in your advice. He just wants to drink his beer on this beautiful island. So that is my father-in-law. I get to see him next week for Christmas, and once again I get to say, hey Jerry, I showed your picture during the diarrhea part of my talk. So boil it, peel it, cook it, or forget it, sort of the travel medicine phrase. The bottom line is people aren't going to listen to us very well. And you offer the advice, and there's great resources on the CDC website, but people tend not to follow this advice when they get to their destination. In fact, in a study done looking at Swiss charter tourists, look at this, 97% made a food faux pas within 72 hours of arrival. So we get there, we're excited, and we're going to do things maybe we shouldn't. So we tend to focus on some therapeutic interventions. So there's two ways to go about doing it. Using antibiotics daily, which you rarely should do. Very rare travelers need that, and much more commonly, self-directed therapy. So when to consider this daily prophylaxis? I'm going to this destination, I have meetings for the next 3 days, I can't afford to miss a meeting, and I need something to prevent diarrhea. Okay, fine. I have a creatinine of 2.1 on the best of days, and the heart failure admissions, and I'm going on this trip with my grandchildren, and I just can't afford to get a dehydrating illness or something that's going to impact. Great. I'm immune compromised, you know, you get sort of the theme here. So you can't tolerate a diarrheal illness. And what to use, in general, once daily fluoroquinolones are highly effective in preventing travelers' diarrhea. And this would be something you'd take every day during the trip. A drug called rifaximin, which is an off-label use, has been studied, and it predominantly is good for E. coli. It's FDA approved for the treatment of travelers' diarrhea, E. coli, and it's a very broad spectrum, non-absorbed rifamycin antibiotic. It's actually a neat antibiotic, but that's something to consider. And bismuth subsalicylate, which some of you picked, works. You can see the rates are lower, about 65%. 4-time-a-day dosing is rough. And then what else is going to happen if you take bismuth subsalicylate on your trip? black stools and so forth and such. So it's a lot to ask, and it works, but you do have to take a QID if you want to prevent. So that's a challenge. So most of the time what we do is I tell people to go to Walgreens, Walmart, wherever, pick up some Imodium tablets, and it's very good for rapid control of symptoms. You don't want to take it if you have a true dysentery sort of process, so explain what that is. And then you say, okay, take that for symptom control and prescribe one of these. And you really have three major choices. The workhorse still are fluoroquinolones. And single doses usually are just fine for eradicating the symptoms. And what I tend to do is say, well, I'm going to give you some Cipro or levofloxacin, it doesn't matter. Take a dose in addition to your loperamide. If you get better, great. If not, take another dose. You can go up to 3 days or so is sort of a rule of thumb. If you have fevers, bloody stools, don't mess around with this. Get help wherever you're at. So that's a way to handle the self-directed therapy. Most people will have enough control of their symptoms between loperamide and a single dose to be just fine. When I have folks going to Southeast Asia or Eastern Asia, I very seriously consider azithromycin, which is highly effective against those quinolone-resistant pathogens like campylobacters and so forth, especially if they're going to be there for an extended period of time. And that's 500 milligrams, again, for one dose or up to 3 days. Rifaximin is an alternative, and it's been FDA approved for E. coli traveler's diarrhea. It's 3 times a day dosing and a little more expensive than some of these other choices. But that's a good way to think through it. So bottom line, do a risk assessment. Can they afford to get it? What about that destination risk of resistant pathogens? And I caution you about extended time in parts of Asia. Talk about safe food and drink and realize no one's going to follow your advice, and self-directed therapy for most travelers. Okay. All right, well, let's go to other parts of the world with this famous traveler. So a 52-year-old is traveling to Kenya, and he's going to be there for 3 weeks. And he takes lisinopril for his blood pressure, and he takes paroxetine for some anxiety. And in addition to personal protection measures for malaria prevention, what would you recommend? So we have the menu of malaria drugs here. Who wants to put them on chloroquine? No takers there. How about mefloquine? A few there. How about doxycycline? More there. Azithromycin? Excellent, no takers there. How about atovaquone proguanil, Malarone? And we got a few there. Okay, so vaccines, traveler's diarrhea, and malaria. So let's talk about malaria. Malaria is, of course, a very interesting worldwide problem, and these guys will make you sick and can certainly impact our travelers. And there's resistance, but they're not going to kill our travelers. The main risk, of course, is falciparum. So falciparum is one of the true few infectious disease emergencies in a non-immune host, meaning they did not grow up or they haven't spent a lot of time in a malarious endemic area. This is a situation where you can get into trouble very, very quick. So our recommendations are driven by the risk of falciparum and the risk of falciparum resistance. Most of the world has drug resistance, and that's what drives our drug choices to sort of start. What we're going to do is we're going to look at that resistance, and then we're going to fine-tune our choices based on the individual traveler. This is where we get into trouble with severe complications, et cetera. So that's the malaria that we're mostly concerned about. The darker areas here is where we have chloroquine resistance. So you can see most of the world, in terms of a lot of the destinations here, have chloroquine-resistant falciparum malaria. There's only a few parts of the world that doesn't, and that don't have chloroquine resistance. Parts of the Middle East, parts of generally Central America. But the vast majority of the world, chloroquine-resistant falciparum predominates. And what we need to do for our travelers is to accurately do that risk assessment. Do they really need it is actually a key question. If I'm going to go somewhere where there's a risk, but I'm going to stay at the Crowne Plaza and not go outside and attend meetings for a few days, I probably don't need anything for malaria, even though if I were to take the guide or the tour or whatever, I would. So you have to sit down and figure out what they're going to do and do they really need it. Itinerary accommodations, time of year. The website's good, but this is a telephone number I encourage you to keep in mind if you're in these situations. It's great. You actually get people when you call it, and it's hard to get them off the phone, in my experience. They're really excited to talk to people about malaria. Not just prevention, but this is a great number to call if you're actually treating or evaluating someone with malaria. It's the malaria hotline. One time I called and I got Hans Lobel, who is a very, very esteemed researcher in malaria, travel medicine. He taught me so much about malaria. He goes, do you want to know why there's so much drug-resistant malaria in the borders of Thailand? And my patient was going to Central America or somewhere. I said, sure. So I got a lecture from him. I'm not saying you're going to get a lecture when you call the number, but it's a great number. And what we want to do is risk assess, and we want to protect against mosquitoes in the ways you're familiar with, and we want to use chemoprophylaxis. So how do we choose? The risk of falciparum resistance drives it, and then we're going to tailor it. So let's say we're going somewhere where there's no chloroquine resistance reported. Chloroquine's still a terrific drug to use. You need to start it early because it's a long half-life, 2 weeks before departure. Take it for a month later. This is a weekly dose. Now, why such a long time? Well, if you get the malaria organism, the falciparum organism, remember it's got a couple of phases, the blood phase and the liver phase. And that particular drug, like most of them, works on the blood phase but not the liver phase. So if the organisms are in the liver phase, they can come out and you won't have any drug around to take care of them when that happens after you return home. So we have to take it for a month after you get back. It can't, well, it depends. Oh. Yeah, I used it recently. Okay. Got it. Okay. Well, good point about availability. I used it a few months ago in a gentleman, but your point's well taken. If chloroquine resistance is reported, you have some choices here. And this is where most of the time you're going to be in the decision making. So remember what our traveler had? Lisinopril for hypertension. But what else was he on? He was on Paxil paroxetine for his anxiety and depression. So mefloquin's a drug that the weekly dosing that we use for prevention, he probably would do okay, but as you know, there's a fair amount of concern, a lot of angst, anxiety, and a lot of real things about mefloquin, especially in the setting of things like pre-existing mental health conditions, cardiac dysrhythmias, fine motor skills being impaired, and so forth. Most of those items occur at treatment doses. So if we rarely would use mefloquin to actually treat. The treatment doses are much higher than prevention. Nonetheless, we have other options here. So we probably would stay away from this in our traveler. Malarone is excellent. You start it before you leave. You only have to take it a few days afterwards because it actually does have some activity on the liver stage. So that's good. Doxycycline, take it every day, but what's the downside of taking doxycycline? Photosensitivity, right? So someone who's already been battling a lot of skin cancers and so forth might not be the best choice. Primaquine can be helpful, but only do that if you're getting specific advice. So let's look at Kenya, where this traveler's going, and the risk is in all areas under 2,500 meters, but there's no risk in the highly urbanized central part of Nairobi, for example. So if your traveler's going to Nairobi and not going to really do anything else, you don't need to do anything about malaria prevention. And it talks about the drug resistance, the major species, and then the recommendations. So this is, again, from the CDC website, and this would be right underneath the vaccine section I showed you earlier. Why do I really bring some of this up, even the chloroquine? It's because studies like this, where we look at returning travelers, and they were either put on the wrong prophylaxis in this case, all were given chloroquine, but they were going to chloroquine-resistant areas. And of course, when you look at about 5,000 cases of imported malaria over a decade, 20% took the wrong regimen, and over half took no chemoprophylaxis at all. So malaria is a big deal, and it's important to be precise about these recommendations. This is a topic for a different talk, but one of the travel medicine tenets, someone comes back from a part of the world where there's malaria, they have a fever, falciparum malaria absolutely has to be on top of your list. It's not the only thing on the list. There's a lot of evil customers on this list that you have to assess simultaneously, but you have to have falciparum on the top of your list, especially in a non-immune host, because they're the ones that will quickly get into trouble. So one of the tenets is undifferentiated fever in the traveler returning from a malarious region is malaria till proven otherwise. Importantly, whether or not they were on prophylaxis. So even the best prophylaxis can fail. Even the best intentioned patient can fail to take the prophylaxis, all those different equations. So always have that on top of your list. Another nice picture here. Let's go to the beach. And here's a couple cases. So this is a UW is University of Wisconsin. This is a college student I saw in our ER. And she spent some time in South Africa. She was there for about a month. And she came, actually, while she was there, or I'm sorry, when she came back, she got a rash and a febrile illness. When she was over there, about 10 days into her trip, she got a cough, and she saw a local physician put on Augmentin. And at the same time, she noticed a nodule on her left thigh. And this is what it looked like. So this is a picture of what her left thigh would have looked like. So keep that in your mind's eye. And then she started popping these up elsewhere. So she got one on her neck and her right forearm. Then she started feeling a little crummy with fever and chills and so forth, and a headache. And she returned to Madison, went to urgent care, and had a negative chest x-ray and was put on dicloxacillin. I mean, you know, I understand why that would be a very appealing thing to do, and, you know, it looks like it could be a staph boil or furuncle or something, right? She received a Hep A vaccine before she left. She took her mefloquine as directed, and she stayed on a hunting ranch, and she did a lot of expeditions during her time there, a lot of animal riding, hiking, scuba diving, and no new sexual contacts. So when I saw her in the ER, she actually was quite alert. She was lucid. Despite her headache, no concern about mental status. Her vital signs were stable, and she was afebrile. She had a diffuse rash all over, actually, mostly a papular component. She had 4 eschars on her left thigh, right neck. You can see different areas as I've described. And her labs had a mild transaminitis, and her CBC was actually normal. So here's an example of the papular rash that she had. So what she had here, you might say, well, come on, doctor, you're an ID guy, this is a zebra. Actually, it's not. This, what we've seen in the last 5 to 10 years is a tremendous uptick in travel-associated rickettsial infections. If I go back to that list of undifferentiated fever, about halfway down you'll notice rickettsial infections. And there's an incredible array on a worldwide basis of rickettsial infections that travelers can acquire. The number one rickettsial infection in travel medicine is actually African tick bite fever. And this is an infection that you have to be aware of in your travelers coming back from parts of Africa. And the way it works is that this particular rickettsia is transmitted by cattle ticks. And these ticks are amazing. These are very aggressive ticks. They're not just hanging out on the vegetation waiting for people to come along. They're going after people. And they have tremendous sensors for lactic acid and carbon dioxide and all this stuff. And they tend to come out, or they tend to be in swarms. So you actually get clustered cases. So you might have a traveler come back and anybody else in your party gets sick. Oh yeah, this person and this person has a similar thing. Multiple eschars are common with this because multiple ticks tend to be out there. And the tick infection rate, in other words, how much of the time does the tick have the rickettsial organism, is pretty high, about 50%. So the history is important. So the classic history is taking hikes, animal rides, just like this young girl had, especially out in the rural areas where there's a lot of vegetation and so forth. So it's not only an emerging, but it's the most common rickettsial infection in travel medicine. This is what it would look like. So again, I can't blame anyone for thinking of dicloxacillin for a staph furuncle or some anti-staph agent, but in this case, the history was important, and it's common to see these multiple eschars like this in this particular case. People come in with a flu-like illness, like a lot of non-specific rickettsial things start, and you can see that in this particular case, unlike some other rickettsial infections, you're usually going to find the site, if you have them look close enough on the skin exam, you're going to find that initial eschar, and you might even see multiple eschars in up to half. Lymphadenitis can occur, and then the typical rickettsial things, they have a headache and a fever, and they don't feel well. They have myalgias, and this disseminated rash, like this lady had, is actually see about a third of the time. Serology is how to diagnose this, but it won't do you a shred of good when you see them because it will take a long time to come back. So just like Rocky Mountain spotted fever, just like anaplasma, just like Ehrlichia, just like all the rest, if you think about a rickettsial infection in whatever context, you got to start them on antibiotics. So you have to start doxycycline with a suspicion of this particular entity. And in this case, I put her on doxycycline in the ER. She had there with her mom. The next day I called her. Already she was feeling a lot better, which is a classic sort of story for rickettsia, rickettsial-like organisms like anaplasma and Ehrlichia and so forth. They get better pretty quickly. And just because we were suspicious for this doesn't mean we stop, right? So we have to look for other things. So you bet she got blood culture. She got a malaria smear despite her prophylaxis, looking for some other things. You know, the negative sexual history, you still want to look with consent, so we looked for some things, to always think about dengue and so forth. So these tests came back negative. And 2 or so weeks later, you know, out of the blue comes the serology, and in fact, she was seropositive for that organism. So this was a case of African tick bite fever. Here's a case. Here's a gentleman who shows up with similar symptoms. He's got fever and myalgias, a terrible headache, and his eyes really hurt for a couple of days. He just got back from the Dominican Republic. He took doxycycline for malaria prevention. Now, he's a little on the sicker side, vital signs. He's got a fever, and his blood pressure might be a little low, but he's alert, he's lucid, he's just in terrible pain. And no meningismus, but he's got a petechial rash all over, and you see he's got some cytopenias here with his white count, platelet count down, and he's got a transaminitis. So, remember, he's coming back from Dominican Republic. He took his prophylaxis, but we're locked and loaded to send that malaria smear. So as we type away and order our malaria smear, which is what we're always going to do, what's on top of your differential diagnosis? Is this breakthrough Vivax malaria? Is it doxycycline-resistant falciparum? Is it dengue? Is it chikungunya? Or is it Zika? I hear dengue. Dengue going once, going twice. Chikungunya, I saw several hands. Yeah. Either one of this. So the way to approach this, as we'll talk about, is always think here, but unfortunately now we have to think here. So we'll talk a little bit about that. So they're here, or they're close. Well, who are they? They are the Aedes mosquitoes. This guy over here, Aegypti, came to the US on ships more than 300 years ago. A lot of outbreaks in different eastern seaboard regions. Philadelphia in 1780, New Orleans in the late 1800s, 40,000 cases of dengue fever, complements of this guy here. This mosquito, albopictus, arrived in the 1980s, and both of these vectors are widespread in the United States. So you look at the distribution of Aegypti, and you can see it's mostly where many of you live, and it's making its way north. Albopictus is got a far greater reach into the Midwest, the East Coast. So the vectors are here, and the theme that they bring is transmitting these infections from infected humans to uninfected humans. So the Aedes trio, as it's being called now, is really a trio of 3 viral infections. Dengue fever, which you're familiar with, breakbone fever, which is the #1 mosquito-borne viral infection that we think about in these circumstances. And chikungunya, which many of you also recognize, has been the new kid on the block since 2014 in this part of the world, meaning the Americas. The newest kid on the block, however, is Zika. Zika is a virus named for the Zika forest in Uganda, where it was initially isolated. And there's been outbreaks of this particular virus there for a while that have been recognized. But what probably happened is a viremic individual attended a soccer match in Brazil and attended that match, and probably was part of the reason why now Brazil and other parts of South America are seeing a lot of Zika infection. And so it's here, meaning it's here in the Americas, so our part of the world, and it's just a matter of time before it spreads further. And when we think about the risk of, for example, dengue transmission, a lot of areas at risk, the number of cases in the Caribbean, the number of cases in Mexico, et cetera, Africa, all the many popular traveler destinations are very, very high and off the scale. For a while, the Caribbean had an extremely low amount, but the Aedes was never completely eradicated from all the islands, nor was it eradicated from our country, and then since the 1950s, it's really flourished. Dengue is breakbone fever, and this is the one you want to have on top of your list. There's a lot of destinations at risk. You incubate, and then you come in, and you really feel awful. You have a fever. That eye pain is classic, the terrible muscle pain, the retroorbital pain, and many of these folks come in with arthrolysis and a rash. The tricky part about dengue is that typically people will start feeling better after a few days. That initial fever will break, and then you can go a couple different routes. You can continue to get better, or right after the break is when they can kind of resurge on you and get sick, and that's when also a rash can appear. So after a few days of fever, I have a break, and now day 5 and 6, I got a resurgence with a rash. A lot of cytopenias, transaminitis. Most cases will go away after a few days, but the effects can last many, many weeks or longer, actually, residual fatigue, et cetera. This is a sort of a classic course of dengue illness up here over days, and I just want to highlight this region right here around day 4, 5, 6. It's called the critical zone, and it doesn't mean everybody's going to get critically ill. It just means after that initial recovery, they can go a couple different ways. They can actually get better, or this is when they can start getting sick on you into the severe dengue illness, the hemorrhagic, the shock syndromes, and that. So don't pay attention when they start getting better and hope that that's what it continues, but it also might be a different story. Severe dengue, thankfully it's not as common, but they will deteriorate on you rapidly. And this occurs when people have been exposed to different serotypes over time. You diagnose it with serology and PCR, and I've given you some guidance here about when those tests might be most useful. I usually send them both, and then you monitor them. Fluids are very important up front. Watch their eyes and nose, avoid nonsteroidals, and we rarely have to transfuse. Now, I should have taken a look last night. I didn't, but at least as of late November, Hawaii was up to almost 90 cases of dengue with an outbreak. Most of it on the Big Island, as you see here, and the CDC, and a lot of concern. So dengue can sneak in and get us in a variety of places. Chikungunya is the one that is getting a lot of attention now, and that stands for that which bends up. And basically, it's transmitted by the same mosquitoes, a similar kind of illness, and joint pain is the real legendary part of this infection. Bilateral, many joints, big joints, small joints, and it can go on for a long, long time. Just recently reported has been some cases, unfortunately, of fatal encephalitis and some neurologic outcomes that we never really thought were part of chikungunya, but now a small fraction of people are experiencing those. Similar presentation here, life-threatening and rare, but we're learning more about some of these neurologic complications, PCR and serology. Just about all the states have reported travel-associated chikungunya. And in Florida, the reason that's darker color is because there's been at least 11 cases transmitted there in Florida. When it hit the Caribbean, it's just taken off like wildfire since 2013, St. Martin, when it was first recognized there. These are data from our infectious disease meetings in October, just showing where most of the infections come from and the risk there. So you can see that there's some very, very high-risk travel destinations. So how do you separate these? You really can't clinically, is the bottom line. Dengue's number one, chikungunya's on the rise, and since we can't tell them apart, assume it's dengue if you're concerned about one of these syndromes until you know otherwise. And the way that this generally works is chikungunya is basically dengue plus arthritis. So that's one way to think about it. But so fever in a return traveler from these high-risk destinations, think dengue, always rule out malaria, and look for both. I'll wrap up with a couple things. STD risks here, sun, sand, and sex. So the risk of STDs in travelers is very real. I saw a gentleman just about a month ago. He was in his 70s. He was going to Thailand, just showed up for a pre-travel evaluation in our VA clinic, and I said, oh, okay, what are you going to do in Thailand? He says, well, I have several girlfriends in Thailand. Okay, and he had been there a year before, and he had no pre-travel assessment then. I said, hey, ever hear of that hepatitis B? And he said no. So his surface antibody was negative, and so he was going to leave in about 5 weeks. So that was a good example where that accelerated Twinrix got him Hep A and Hep B protection. And I said, please come back and finish that out when you come back. So the risks are real, and you can get a lot of different things around the world. So think about this, ask about it. In a Peace Corps worker study, a lot of people had sex and most people didn't use condoms or used them inconsistently, so STDs are alive and well in travel medicine. So I hope the framework is helpful. Don't forget the Hep A, think about malaria, correct drug selection. That's tomorrow if you're interested. Hep B, which Dr. Sanyal alluded to. Dengue, high on your list, also chikungunya, and probably within the next couple years or so, Zika will also be on your list. I'm going to wrap up with a slide. This is from Jay Keystone, who's one of the preeminent researchers and clinicians in travel medicine, who teaches us a lot on the infectious disease side. Travel medicine for dummies: don't get hit, don't get bit, don't get lit, don't do it, and don't eat. I'll let you fill that one in, right? So, thank you. Looks like a few minutes for questions, Kathy, or yes?
Is there any use for Hep A, Hep B boosters for those of us who travel a lot and might have received those immunizations 20, 30 years ago?
Yeah, Hep A, Hep B boosters travel a lot, received them a long time ago. There's no formal recommendations for Hep A, so it's a 2-dose series. And that one, I've never seen any recommendation for boosting. For Hep B, it's not uncommon to have your serologic response wane over time, get below that threshold of 10, but now it's still there, primed to protect. What I do in some folks for Hep B is I'll check a surface antibody, and if you haven't checked a surface antibody and you travel a lot, it's probably worth doing. I'll also check this in high-risk individuals, HIV, dialysis, whatever the case may be, where we really ought to know what their surface antibody is. And if it's undetectable, then oftentimes I will give them a boost, and then I'll recheck it in a month. And if it's undetectable then I'll repeat the series. And so there are some considerations there. If you're otherwise healthy, you should have had a high rate of seroprotection and conversion from your original series. But if you consider yourself at risk, Hep A is going to be, the fecal oral foodborne, risk. Hep B is going to be body fluid sharing. I raised the point about motor vehicle accidents. What if you're somewhere and you need a transfusion and so forth, which would be the main risk for a lot of travelers. But it would be worth checking a surface antibody for Hep B. Yes? A vaccine for Ebola. Hopefully someday there will be a vaccine for Ebola. Work is being done for Ebola and many other hemorrhagic viruses, but I don't know any specifics about that.